So now we will come to the panel discussion. Today, we have the chance to bring together our leading voices across different disciplines and regions to share their insights, challenge ideas, and explore the future of ultrasound in both diagnostic and therapeutic applications. So please join me in welcome our 6 speakers to the stage and give them a warm round of applause. So we will have Professor Cui from Beijing University Third Hospital from China, Professor Dick Andrea Clevet from University of Munich, Großhaden Campus, Germany, and Professor Liu Zhen from Xinqiao Hospital Army Medical University of the PLA, China, and Professor Luciano Tarantino from A. Toronto Oncology Hospital from Italy, and Dr. Asif Mami from Bashia Hospital, India, and Dr. Dong from the Beijing Hospital, Shanghai Jiao Tong University from China. So have them all seated, please. So thank you all very much for your wonderful presentations. And today is our great honor to have this deeper engagement with all of you from China and also from the international markets. So because we have a little bit behind the schedule, so I will just select some very important questions from our audience today. And the first question goes for Professor Clevert. You have over 2 decades experience in the clinical radiology and ultrasound, and always at the forefront of ultrasound innovation in Europe. So we would like to take this opportunity to ask you one question and hear from your expertise. So our question comes from your clinical experience. Which organ or pathology do you see the URM having the biggest potential in your routine diagnosis?
I think that's a very good question. Of course, we have to think about where we will get the most benefit from this new technique. And of course, we have to look for an organ which is stable, so which has less motion. And so if you think about superficial organs like thyroid, breast, testes, lymph nodes, salivary glands, that could be fantastic organ because we have already can use the linear probe with a high resolution, less motion, probably the examination will have got a high quality. And of course we have to think about cutoff values. Which number is normal, which number is abnormal. So there will be a lot of work in progress for the future for all of us. And I think if we work as a team together, probably we can speed up this new technique very fast.
Thank you, Professor Clevet. Okay, so the second question goes to Dr. Dong. You have brought us a very compelling view of how the SRUS can be applied, not only the breast, the thyroid, those diseases, but also exploring the synthetic system. So very true frontier in the microvascular imaging. So our question is, in which clinical fields does the super resolution ultrasound have potential applications? So for example, are there already some successful cases in the fields of the tumor detection, cardiovascular disease, and obstetrics and gynecology?
Thank you for your question. But actually, I'm an ultrasound doctor just focusing on superficial organs. In our department, we are very strong in thyroid gland and the breast and lymph nodes. But I think there are still some potential applications that we can use in gynecology and cardiology. For example, maybe some cardiac disease of cardiac muscles, but I think it's very hard for technical realization because of the heart just beating. It's very hard for URM to capture. But I think it's a very, very promising aspect. If we can do some technical breakthroughs, I think this is a very good potential application in clinical work. And also in gynecologists, because we all we also do some evaluation of gynecology sometimes. We think some of the URM applications that we can do to compare from different subtype of disease, or for evaluation or assessments after, before and after treatment. I think they are all very promising fields that we can do something new. Thank you.
Thank you. Thank you, Dr. Dong. So the next question, I would like to go to both Professor Clevet and Dr. Asif, because you have already exploited URM in your countries. And so what do you see as the main challenges in translating URM from the research to your routine clinical practice in your countries? And how do your clinical system coordinate between the physicians, the patients, and technology to make this transition successfully?
I think Dr. Clevert uses a lot of ultrasound contrast. In my country, not many people use contrast because the main challenge is the cost, and there is a little bit of competition with the other cross-sectional modalities. So in the same cost, sometimes the other modalities are used, so it's the clinicians at times do not prefer the contrast enhanced ultrasound. So if the contrast enhanced ultrasound becomes a little cheaper and easily available, then there are a lot of applications. And in fact, we prove it to them that on table when we use it without making the patient go through further additional imaging, that really kind of impresses them and they're really happy about it. So the cost of contrast, if it comes down, it will be nice. And we know machine eye realized that the contrast dosage which is required was less, which is very good. So we can combine a couple of cases together and do it in the same go. I think more using more than one or two patients in the same time, which will make it more cost effective. So that also is a kind of challenge, that having to compete with the other cross-sectional modalities can be sometimes difficult. But main crux is without being worried about the renal toxicity, if we can use contrast with such a fine detail, which can be impressed. So I think we need to educate people in, and that will help us. I'm sure we can do that.
Thank you, Dr. Asif. So what do you think, Professor Kleber?
I think, first of all, we have to standardize the examination protocols. We have to think about what will be the perfect dose for which organ. Therefore, I think there's a big need for have international studies with multi-center studies, that we combine all the knowledge worldwide in one preset for one organ. And I think this will be probably a challenging job because a lot of work for the future.
Thank you. Thank you, Professor Klebert. So speaking of the multi-center, actually, I also have a question for Professor Cui and Dr. Dong, because you have already launched your multi-centers in China. So my question is, what are the current limitations in URM adoption at a hospital scale, and how we might overcome those challenges? So, yeah, Professor Cui, maybe you can share some ideas.
Yeah, it's for the multiple center research. Actually, for me, it's the first time I to be a PI to do that. You're right. So it's a very hard work to make the research fluently within the group. Sometimes I think the first important one, before you launch the study, the research, you should do enough communication with others to discuss what really we want to do, why we want to do this, and what we hope to find with this study. When everyone achieves the same aim, it will be easy to go together So I think that's a little bit similar to the growing of Vino, as Mr. Xi told us this morning. So at the beginning, 15 years ago, it's just several persons, but right now it's around 700. So why? Because this group has one aim inside. So let's say about the multiple center research is the same thing. If we have the same purpose, that will be easy. And to perform the research, go through quickly and fluently, I think the details is very important. Actually, I learned a lot from Professor Jianqiao Zhou's group and also Dr. Dong. They did a lot of work, and I learned from them how to perform a multiple research. That's what I can say. I think Dr. Dong has more.
Thank you, Professor Cui, and thank you for your encouragement. And we will continually support your contribution to the medical field. And Dr. Dong, please.
We already done the multi-center of breast lesions in our in Region Hospital. I think it's just the same question of Professor Sung, because actually in some lower grade institution in China, we still have no chances sometimes to reach contrast enhanced ultrasound because they cost more. Yeah. So at that time, I think the Vino collaboration, they are very, very hard for them because not only they have to support the devices, but also they have to solve all these problems, just like the lack of drug, the lack of teachers to teach them how to do contrast enhanced ultrasound and how to do URM. So in our department, we have to maybe hold our meeting at least 1 month, online. Every month we have to do this to teach our doctors in lower grade institutions how to do contrast enhanced ultrasound, how to capture the URM, and how to make your image quality to be controlled. And because only when you control the quality of images, then your parameters and your results of analysis will be accurate. Because URM, the most important advantage is the quantitative parameters. But the quantitative parameters, there's a lot of problems or a lot of influence factors will make bias. So I think this is very important for an institution like us, because I have a very strong leader, Dr. Jianqiao Zhou. Every month we have to hold meetings. Again and again, we will told our doctors to make your probe stable, okay? And make your contrast agents dose to be accurate. Because for multi-center studies, you are unable to change any other conditions. It's not like what you are doing in your clinical work. This study are different from just the clinical work. I think this is very important to let all the doctors that's coming to our multi-center studies to know that this difference. And thank you very much for our Vino collaboration, because all of these studies, they cost a lot, not only money, but also your time, your energy. Yeah, thank you.
Thank you, Dr. Dong. And I think you also have taught us a lot from your clinical point of view. So engineers, we are all every day learning from you, and we are really looking forward to the trip tomorrow, so we can learn more from you. Okay, so the next
Sorry.
question. Yeah, sorry.
Sorry, I want to add something. I have a little bit different opinion to what Dr. Dong said. Actually, I do agree research study is different from clinical routine practice. But after the training, I mean, to the details about the research, it's a good way to combine research study to the clinical practice. I mean, if we combine those together, that will be more convenient to do research. Especially for us, we have no powerful leader situation. So, thank you.
Thank you, Professor Cui.
Is there any formal name for these techniques? Because somebody called super resolution, super fast, but I prefer to use bubble tracking, the professional name. What's is there any formal name like now accepted in, for this technique?
Except URM?
URM, ULM, I saw a lot of them.
Yes.
Yeah, I agree with Professor Liu, but I think it's a common phenomenon, especially for a new technology to come with us. There's a lot of chaos. But after a time of study, after many professors joined into this field, finally, I think we can come to a consensus. We will give it a right name later. So right now, just like the, how to say that, bullet goes through to fly for a moment. We'll see.
So I think sitting here is all the pioneers in this ULM or SRUS or URM. So I think we are going to change the era of the ultrasound to make it more precision. So our work is in front of us.
What's the name Dr. Tanner and Tom Xin said about this word?
ULM, I see.
ULM. Ultra localization microscopy.
Yes.
Oh.
Yes.
Okay.
Thank you, Professor Liu. And actually, I also have a question for you and also Professor Tarantino. So we know as ultrasound technology evolves from now the pure diagnosis and to the real-time imaging guided therapy. So whether it's through the cavitation enhanced drug delivery or IRE, as Professor Tarantino mentioned, application, how do you envision the integrating the diagnostic and the therapeutic ultrasound into an ununified workflow? And what are the technical or clinical milestones we have to overcome to get there?
I'm rather old, and I prefer my first ultrasound-guided biopsy in 1982. Then my first radiofrequency ablation in 1996, and I used for the first time in 1991 Sonoview for these procedures, and I have the privilege to follow the growth of all this technique. And I can say that now, after 43 years, I'm not fully satisfied. I want to grow still. But I can say that now we have the opportunity to follow, and I'm very interested in the microcirculation enhanced with Sonoview, for the detection, but the characterization and the efficacy assessment of this technique. This for the ultrasound-based part of our work, our job. That is growth, is still growing, and it's, I could see in this machine that I had the privilege to use in this last month that it's very, very accurate in answer to our need. Yeah, I think that together with the non-invasive technique, ultrasound should also be coupled because of the friendly use in surgery, and in all this, the invasive technique should be should have the care to perform and to project other way to approach the patient. And I can say this because I actually have two schools for ultrasound for surgeons in the Naples University. And now, since I can say, I diffusely, because ultrasound for surgery, mainly for liver surgery, is I have a long story, but the diffusion of this use in of the use of the ultrasound guided in surgery, mainly now laparoscopic, is as a relatively recent history. So this should be one of the projects of a brand like Vino to perform, to enlarge and improve the approach to this invasive technique. This must come from many improvement of technology, and that will come in the next years probably. And also, together with the application, like application that already I used with other brand, the fusion and the navigation that is so useful when in operatory room you use an ultrasound machine that has all this important, strong software inside. That's the next future, I think.
Thank you very much, Professor Tarantino. And what about you think, Professor Liu?
It's too early to say this therapeutic ultrasound can go how far in clinic. But ultrasound guided intervention had been accepted and very popular in the clinical. But in my field, low intensity ultrasound could be a major therapeutic method in the clinical. I would say it's too early to say, but these techniques is featured with very low intensity, non-invasive, easily accepted by clinical. I think it will be an opportunity. It had opportunity to become wide accepted in the clinical, because ultrasound, obviously, the diagnostic ultrasound had been accepted and easily accepted in every country. And the insurance company would like to pay it. It's non-ionic. It's if doctor want to do CAT scan and CAT scan in Europe or United States, the patient have to sign the treaty that X-ray is harmful. But to ultrasound, the patient, you have to do it. So did the therapeutic, low intensity therapeutic ultrasound. It's completely non-invasive, non-ionic, and very accepted by the doctor and patient. But it maybe take a decade or 2 decades to go to become popular in clinical, because it's easy to perform, but sometimes it's difficult to understand the mechanism. So every department have to buy this machine, because the machine had to be bedside, not in the department of ultrasound. So that's a problem. So it takes a long time for the clinical doctor to accept that the routine therapeutic method, I think.
Yes, maybe 1 decade or maybe 2 decades. As also the URI.
Just like the contrast ultrasound, it takes
exactly.
like a decade to become popular in the clinic.
Right, right.
Actually, this problem, this aspect is different from country to country. In Italy and in Europe, in Germany, I think Dr. Keller could confirm it, is there is no substantial selection, but every, this is the world of clinical physician in the present and the next future, that is a powerful tool to visit and to try and to treat the patient, for not being an option for every specialization. And I think that we are near to this. In Italy, every specialist use with a good competency or a bad sometimes, but is very diffusion. So it depends on the country.
Actually, I have a question for these two European doctors. And you know, the contrast, the microbubble, is approved only for the diagnostic use. But in our study, it's obviously it's a therapeutic use. In Europe, do it have to pass the new drug or FDA, like in Europe? Is it very difficult to do it in clinical? Because the first study was done in Norwegian, I think, by Davinsky, that doctor. I would say he didn't pass the FDA to use it as a therapeutic drug, but a diagnostic agent. Do you have to pass the FDA?
Yeah, you have to pass the EMA, the European. Yeah.
EMA.
Yeah. And if you go worldwide, then you have to pass the FDA. Yeah.
Oh, that will take so long.
And a lot of studies and money.
Yes. Maybe the contrast company would like to pay it.
They can work together, of course. Okay, so because we have, I wanted to invite some audience, but the time is, the clock is ticking, and I do not want to take up, our precious lunch relaxation time. So I would just thank you very much to all our professors and the doctors for your invaluable insights to share with us. And we're looking forward more combination of the innovation and the clinical working together with you. Thank you very much.